As we look at Levi, take your hands out like this. You'll see that the station of his hand, this is a valgus, it's a normal valgus. We look at his shoulder girdle, this is normal. Landmarks, they're doing great. Now for the simple part of the exam. Levi, you're going to do exactly what I tell you to do. Okay? Why don't you take your hand, bring it up over your head, just like this. Go like this, and go like this. Put it down by your side. Same thing with the other shoulder. The other hand, like this, and behind your back. Okay. Then put your arms down by your side again. Go like this. Press hard. Notice these guys get big. Put them down. Bring your arms up. Bring your arms down. Put your hands like this. Roll them in. Roll them out. Fingers open like this. Okay. Now, I want you to pretend like you're hammering. So again, go like this. Hard. And let's do it with the other hand. Now I want you to turn to your side here just so the camera will see. And I want you to pretend like you're throwing a spear. Okay. Same thing. And do it with the other hand. Okay. Did any of that hurt you? No. We have a sensory area, the deltoid, right here. Levi, do you feel that? Yeah. We have a motor, the deltoid. Levi, hold that right there. Don't let me move it. I can palpate the deltoid. Put your arm down by your side. And we have a specific reflex, the biceps reflex. And I can use a reflex hammer, or in this case, I can elicit it with tapping of my fingers. That was C5. Now C6. Do we have a sensory area for C6? Yes. Make a letter 6 just like this. And this is C6. That's the sensory area. The motor for C6 is the biceps muscle, so hold it right there. And the reflex for C6 is a brachioradialis, right here. Now we'll go to C7. In C7, our sensory area is middle finger, middle finger. The motor area of C7 is the triceps. Push against me. Boom. And finger extension. Just go like that. Against resistance. Okay? And relax. Now, there is a reflex for C7, and that's the triceps tendon. So now we've gone through C5, C6, C7. C8 and T1 do not have a reflex, but they do have a sensory area. Okay? C8 sensory area is the small and the ring fingers, the forearm. Spread your fingers apart, bring them together. Finger flexors and the intrinsics, spread your fingers apart, bring them together this way. Okay? And the same with T1. Interossei, hold it together. Relax now. Okay? And the sensory area for T1 is the inside of the arm. We look for the common landmarks. Those common landmarks consist of the trapezium, the clavicle, the spine of the scapula into the acromion. You can palpate a bony prominence right here. That's called the cornoid. We look at the definition of muscle, which is the deltoid. And I can start by just doing surface anatomy. Surface anatomy being, Levi, do you feel me right here?
Yeah.
Okay. So we've got that sensory area for C5. Now, Levi, I want you to bring your shoulder, and we're going to go into external rotation. I'm going to turn you this way. Internal rotation. Abduction. Adduction, adduction, okay? Forward flexion and extension. I put my hand on the shoulder and I feel the glide of the humerus with the scapula, the glenoid. It's smooth, nice, smooth glide. And you also notice that as I do this, there is no apprehension. There's no sense that there's instability of the shoulder. which you would see commonly in a loose shoulder or an unstable shoulder. Now, in this area, as we drop down into and head towards the elbow, there's a couple things that we can do very quickly. One is hold your arm right there. Don't let me move this. Boom. On the same token, I'm going to put your arm there and I'm going to push up. Don't let me move that. Now, I think one of the easiest things in motor examinations, which you just saw, was placing the motor in the position that you want it and having the patient hold it, as opposed to telling the patient to move it for you. We've already seen that in the first segments, and Levi, just relax now. Okay? Telling Levi to bend his elbow and extend his elbow is okay, but this is actually much quicker if you just say, hold it right there, don't let me move it. And that tests his biceps. Put your elbow right there, don't let me move it. And his resistance to me tests his triceps. Same token, if I take his shoulders and put it off to his side like this, say, don't let me move it, and doing it like that, I've tested his deltoid. Now, Levi, put your arms by your side, just on your hips, and press in. And this is a nice way to examine for pecs and for latissimus. In little babies, in newborns, if you reach inside and you're looking for the presence of a pectoralis major and latissimus, even if you squeeze up underneath there, they'll contract down and you'll be able to palpate that. And we look for that in those syndromes where there's an absence of the pectoralis major. I'm going to demonstrate a part of the examination that I use in athletes, looking specifically at the stability of the collateral ligaments of the elbow. There's ways that you can test it to see if it occurs. One of those is just taking the arm and trying to bend it as we go through flexion and extension. Okay? The other is to take the arm, one over the other. We'll take this one over the other like that, and stress it. And we're looking for pain right here, which we'll see in throwing athletes. That's the ulnar collateral ligament, or the UCL ligament, and that will be painful at this point as I'm putting valgus stress against this elbow. The second is to actually turn the elbow into a knee, and we'll, again, as we go into from flexion to extension, you'll find that we're putting, in this case, putting a varus strain on the ulnar collateral, or on the radial collateral ligament side. That's a varus stress on the radial collateral ligament, and we'll also do this simultaneously while supinating, and we look for that entity that is called posterior rotatory instability of the radial head. Now, those are hard tests to do, and a nice way to reinforce the fact that this is a normal examination is to have the patient do a push-up from a chair or from the side of the table. And Levi's going to demonstrate that. So Levi, come here, sit down, and just do a push-up. Let's just do it twice. Okay, do it again. Now have a seat. I'll guarantee you that any patient that has posterolateral rotatory instability or an insufficient radial collateral ligament, or an insufficient or partially torn ulnar collateral ligament, won't let you do that. Or if they do that and they're very good athletes, they'll do it by putting all their pressure or offloading onto the uninjured side. In examining the forearm and the wrist, we start by flexing the elbow. Once the elbow is flexed, we can examine pronation of the forearm and supination of the forearm. And it has to be at an elbow flex position, because if it isn't, and there's pathology here, or there is a congenital difference such as a synostosis, children will compensate for the lack of forearm motion with rotation through their shoulder. So the only way you can eliminate that shoulder motion is by flexing the elbow and then examining the forearm. In the examination of the hand, we first look at the appearance and the station of the hand also. In this normal hand, you'll notice that there's a normal cascade. The hand looks animated. We talk with our hands. some of us more than others. But this hand is animated. It has normal cascade, the extended finger going down into the small finger. It has normal prominence, the hypothenar eminence, the thenar eminence. And as you extend the fingers, which Levi is doing, we'll notice that there are palpable soft spots in between the fingers themselves. And if we take and put it end on, I'm going to have it kind of go like that, Levi. I'm going to push this back here. These soft prominences are not the tendons. That's where the neurovascular bundles are, here and here, here and here. And you can actually feel some of the digital nerves in the hand and in the landmarks. The obvious one is the nerve to the radial side of the index finger, which can be palpated at this crease. And that's that small line there. And you can also palpate the digital nerves that go to the thumb, right at the digital palmar crease of the thumb. Now, in examining the hand itself with normal cascade, it is obvious to us that all of the tendons are intact to their motor units. But I'm going to be very, very specific, and I'm going to break up my hand examination into the component parts of observation. We talked about basic landmarks. Then I'm going to palpate the bony landmarks. And the palpable bony landmarks consist of the radial styloid, which is right here, okay? The pisiform of bony prominence on the ulnar side of the wrist, down here. If I turn the forearm and bring it up here, and I run my finger up on the subcutaneous border of the pronated forearm, and I'm running on a subcutaneous border of the ulna, this ends right at the ulnar styloid. If I turn the wrist over and in this region, come across here and have the patient drop his wrist just like that and hold it right there, don't let me move it, I can palpate the flexor carpi ulnaris, very prominent here, coming across, and the flexor carpi radialis. And with the hand in this position, I can also palpate, and relax just for a moment. I want you to take the small finger, bring it over to your thumb, and I want you to pinch hard, and pinch like that. And in this case, we'll see the bony, or we'll see the landmark and palpate the palmaris longus tendon. 20% of patients don't have that. Levi has a palmaris longus shown right there. And that's an easy way to bring it out, pinching between the thumb and the small finger and palpating it. As we go to the dorsum of the hand, we'll see that there is the radial styloid again, and the ulnar styloid. And as we run our hand across, there's a bony prominence on the back, and that's called Lister's tubercle. If you take Lister's tubercle, which is this palpable bony prominence, about halfway between the ulnar styloid and the radial styloid, a little bit more towards the radial styloid, and you drop your finger distally, you drop into a space, and that space corresponds to the meeting of two carpal bones, the scaphoid and the lunate, and that's where the scapholunate ligament is. Okay? And then you run it a little bit further, and you run in the space between where the lunate meets the capitate, in that area. And so why do we do that? Well, looking specifically for pathology in those areas, those will be painful. Okay? We'll run that across. Now, one of the things about children with their open physes and physeal injuries, very frequently we'll have normal examinations, but as we take and we palpate along the subcutaneous border of the radius heading towards the radial styloid, very often as I come to where the physis is, the child will react, will lift up, will show some pain and difference. And that's because there's injury that isn't showing up on radiographs, but there is injury to the physeal plate. On the palmar side of the hand, looking for the motor in the motor examination, as we mentioned, the normal cascade of the hand is such that the hand goes in this position. Now, we can break it up into its component parts by looking at the profundus examination, which controls flexion of the distal joint or the distal interphalangeal joint of the finger. Flex and hold it there. Same thing with each of the digits. The superficialis tendon is responsible for flexing the PIP joints. And I'll demonstrate that as follows. Make a fist, bend down. That's right, okay? And then bend this down, right there. Perfect. And we bend down there. And if I hold the fingers up into extension, this joint right here is moved by the superficialis tendon. Now it's very important as you realize that as he does this, because of a common belly, the distal interphalangeal joint is floppy. He can't control that because I'm holding it by holding extension of the other digits. This joint becomes floppy and he has no control over it. But if I give him his other fingers, which I'm about to do, he has a very strong grip and it comes down into the palm of the hand. Examination of the radial side and the ulnar side of the hand is a little bit unique in that there's this group of very prominent muscles. And they are, in this case, the thenar muscles. And they're responsible for bringing the thumb out of the palm of the hand and holding it there. And these are the thenar muscles of the abductor pollicis brevis. Okay? And they're responsible for bringing the thumb over to and touching the fingertips as we face. And they come all the way across to the ring and to the small finger. So if you do that, well. And then finally, if we look at the hand from end on, we look at it and we can make it flat, but the normal hand, the working hand, has two arches. Make a fist for me. There's an arch that goes across, that's a straight line between the heads of the second and the third metacarpal, and a line between the heads of the ring and the small finger. So that's a normal arch or a normal position of the hand. And the importance of that in hand fractures is as we look at this hand, we'll note that if you take all of your fingers and keep them straight, but just have them converge down like this, we'll note that they all converge down to this area in line, and that's the scaphoid. Now, a very simple neurologic examination in the hand consists of the following. We can quickly test the motors of the hand in the following manner. I want you to take your thumb and put it in the palm. I'm going to place it right there. I want you to keep it right there, and I don't want you to move. I'm going to push and put resistance against that. The muscle that is responsible for this position is the abductor pollicis brevis. That muscle is always, always, always innervated by the median nerve. Okay, relax. Similarly, if I take the small finger and I, with the PIP joint and the DIP joint straight and put it into this position and tell the patient to hold it there, don't let me move this, not at all. So I push against it, I palpate it, the muscle belly, and that's the abductor and the flexor to the small finger. Those muscles are always, always, always innervated by the ulnar nerve. And then finally, if I have you extend your index finger and I'm going to push or palpate against the MP joint, not against the PIP joints, but the MP joints, that muscle, the extensor digiti communis, or the EIP, the extensor indicis proprius, those muscles are always, always, always innervated by the radial nerve. So a simple motor examination, a quick motor examination would consist of the following. Levi, hold your thumb just like this. Thank you. Bring your small finger, hold it like that. Thank you. Take this right here, hold it there, don't let me move it, don't let me move it, don't let me move it. Boom, boom. I just did a motor examination on the median, the ulnar, and the radial nerve in less than 20 seconds. We're going to do a sensory examination of the hand. Now, in the trauma setting, where we have injuries to the extremity, lacerations or fractures, a child is obviously traumatized. If you approach a child and say, "Can you feel this needle?" they're always going to say yes, okay? So that we need other prompts that may be and are more helpful. An easy tool that I use, I think is very helpful, is to use the serrated or rough edge of a quarter compared to the smooth edge of a nickel. And so I will approach the patient, and I'll take the other uninjured hand, and I'll say, let me see your hand here. And I'll say, what does that feel like? I said, that feels like a quarter, okay? And what does this feel like? That feels like a nickel. And I want you to tell me on your injured hand what you feel. And so I'll have the child bury his head in mom's or dad's shoulder so he's not looking at what we're doing. And I will then ask the patient, what do you feel? Is this a nickel or is this a quarter?
It's a quarter.
Okay. Is this a nickel or is this a quarter?
It's a quarter.
Is this a nickel or is this a quarter?
It's a nickel.
And then at the end of that, you have to give them 30 cents. But I think that the differentiation between the smooth edge and the rough edge, or the serrated edge of a quarter, is a wonderful exam tool. And this is a tool that I was taught by Richard Smith of